We have officially started recording this for anyone to want to listen later. Good evening. I'd like to welcome everyone to tonight's Journal Club meeting. My name is Dr. Victoria Heasley, and it's my pleasure to serve as the club advisor moderating tonight's Journal Club meeting. This is my second time doing this, so glad to be back. For those of you who don't know me, I'm a sports medicine physician, and my subspecialty is in adaptive sports medicine and design and development of adaptive sports equipment. I did my residency in PM&R at the University of Cincinnati and stayed for my sports medicine fellowship. I'm a team physician for UC athletics as well as UC adaptive athletic teams. In addition to my clinical role, I'm also a biomedical engineering professor here at UC. And outside of this, I'm the co-founder and president of my nonprofit, the Bridge Adaptive Sports and Recreation, and we run adaptive sports programming here in Cincinnati, as well as work with a lot of other teams. So the goal of tonight, the goal in general of AMSSM Journal Club is to provide a national platform for student and resident members to present an article from the list of the top 120 articles that every sports medicine fellow should be familiar with. Our intent is to make this really fun learning environment and give this experience for medical students and residents mentoring opportunities with other AMSSM members while developing skills of reviewing articles and making PowerPoint presentations. It's also really helpful for members to be able to listen live or listen later to kind of get a summary of these important articles. So we'll have 3 different presentations tonight. The format that we'll be using is that each presenter will have approximately 20-minute block of time to go over their presentation and some brief Q&A segment afterwards. Anyone who's listening, please enter your questions using the chat function during the Q&A or even while they're presenting if you want to put it in the chat. And then I can either read the question or if you'd like to, I can also kind of call on you and you can read or ask your question out loud too. All right, we're going to start. So I am pleased to introduce our first presenter tonight, Dr. Davis Witt, and his club mentor, Dr. Mark Troxler. So Dr. Davis Witt completed medical school at Sidney Kimmel Medical College at Thomas Jefferson University and is currently a PGY3 resident in family medicine at St. Mary's Family Medicine Residency in Grand Junction, Colorado. He is matched at the University of Utah for fellowship in primary care sports medicine, which he will begin in August 2025. Congratulations. His sports medicine interests include soccer-specific injuries and injury prevention, optimizing performance and recovery for endurance athletes, and the use of orthobiologics in musculoskeletal care. He is passionate about helping athletes of all levels stay healthy, recover effectively, and reach their full potential. A Colorado native, Dr. Witt has deep passion for outdoors and enjoys exploring the Mountain West with his wife and 1-year-old son and their 2 chocolate labs. His presentation is on the article, Greater Trochanteric Pain Syndrome, More Than Bursitis in Iliotibial Tract Friction. I'd also like to thank Dr. Mark Troxler for serving as his club mentor. So introduce Dr. Mark Troxler. He's in private practice at McKinley Internal Medicine and Sports Medicine in McKinley, Texas. He's chairman of anti-doping education for USA Track and Field. He's a team physician for high schools and at the collegiate level and with USA Track and Field. He completed medical school at Oklahoma State University College of Osteopathic Medicine in Tulsa, Oklahoma, and completed his internship year of residency at Hillcrest Health Center in Oklahoma City, Oklahoma, and his internal medicine residency at University of Oklahoma College of Medicine, Tulsa campus at Tulsa, Oklahoma. Dr. Troxler completed his sports medicine fellowship at Jersey Shore University Medical Center and Rutgers in Neptune, New Jersey, and received an MBA degree at the University of Massachusetts, Amherst campus in Amherst, Massachusetts.
Okay, and it looks good on my side, so I will start. So yes, thanks for that great introduction. I appreciate it, and thank you, Dr. Troxler, for your mentorship with this. As we mentioned, I'm going to be talking about Greater Trochanteric Pain Syndrome tonight. More than bursitis and iliotibial tract friction. It's coming from the journal Current Sports Medicine Reports and came out in the year 2012. So objectives of this talk will be to review some of the complex anatomy of the lateral hip in that peritrochanteric region. We'll consider some possible etiologies for lateral hip pain. We'll describe the pathophysiology of what we now consider the principal cause of Greater Trochanteric Pain Syndrome or lateral hip pain, and then get into some treatment options that address not only pain, but really the underlying cause. So just introduction here, physicians of all types will run into patients with pain localized to their lateral hip. This paper specifically said roughly 10 to 25% of the general population will develop lateral hip pain. If you've ran into this before, you can know that it can be a little bit challenging. There's a lot of causes of lateral hip pain, and there's a lot of relevant anatomy in that area to think about. Historically, we've kind of labeled a lot of pain in this area as trochanteric bursitis. We'll get into that, but that's one of the big structures, as well as many, you have your bony landmarks and many myotendinous structures and fascial structures. It hasn't been well described historically, and maybe even led us to maybe think of other causes incorrectly for lateral hip pain. Going back to like 1923, I think was the first time that trochanteric bursitis was named as such, and perhaps a misnomer because there's not often redness, warmth, or swelling associated with this. There can be, but not always. A more recent term that seems to be better to describe most lateral hip pain is greater trochanteric pain syndrome. Kind of considering all those etiologies that I mentioned, tendinopathies, tears, trigger points, IT, friction, inflammation, things like this. This paper encourages us to kind of think about greater trochanteric pain syndrome similarly to rotator cuff syndrome or impingement syndrome in the shoulder, just with relevant anatomy and kind of the pathophys. So we'll dive right into the anatomy at the beginning here. On the left is a coronal and a sagittal section of a right hip at the femoral neck, and it's showing various anatomy. I don't think we have to focus on all these structures. I'll point out the main ones that'll come up. Just adjacent to the hip itself and right near the neck is labeled number 1. That's the joint capsule, and just lateral to that is the gluteus minimus muscle labeled number 2. Overlying that more superficially is the gluteus medius muscle, which is the primary hip abductor and also a major stabilizer of the pelvis. Deep to these muscles, you can see the piriformis, which is another hip intrinsic, labeled number 5. And then more laterally, we've got the tensor fasciae lata muscle, labeled number 9, and the iliotibial tract.
Pass me that speaker, that headphone ring from you.
And then there's going to be the greater trochanteric bursa, labeled number 21, that lies just lateral to the greater trochanter. Oops, I'm sorry, guys. Now, the table on the right is going to talk about more than one bursa here. And in fact, there are 8. That was kind of news to me when I thought about trochanteric bursitis. I kind of just imagined one big bursa, but there's been 8 that have been described. These cushion the gluteal tendons, the IT tract, the piriformis, the tensor fasciae lata at various over that bony greater trochanter area. The most commonly implicated bursa would be the trochanteric or the subgluteus maximus bursa, the genital femoral bursa, and the subgluteus medius bursa. So overall, if you look at this, you can see kind of why there's been correlation or connection to the shoulder with the anatomy present here. But it is quite complex and important to think about all these structures. So epidemiology quickly, as I said, it's a common complaint. This paper indicated, between somewhere around 1.8 per 1,000 patients per year have lateral hip or greater trochanteric pain syndrome, peaking between the 4th and 6th decade of life. Some papers have said female greater than males in predominance. Other papers suggesting they're pretty equal, often associated with low back pain. It's something like 20 to 35% of patients have low back pain and lateral hip pain. What's less clear, and this paper talked about, is that the incidence of the tendinopathy of those two, the gluteus medius and minimus tendons. Bunker et al. Suggested 22% or saw 22% of 50 consecutive surgical patients that were treated for femoral neck fractures had associated gluteal tendinopathy. And then another study with Howell et al. Saw degenerative changes in hip abductors in 1/5 of 176 patients undergoing a total hip for osteoarthritis. And often it's the one of the two sole abductors involved 60% of the time. So now we'll kind of change gears. You've got a patient in front of you and they've got lateral hip pain, and how do you want to go about eliciting more information? So if you talk about, what kind of pain or the story of the pain, often it's chronic, it's persistent, it's lateral, it's right over that bony prominence, or it may be nearby in the soft tissue. It can be acute, it can be insidious in nature. It's likely related to activity of that hip on that side. It can be dull, it can be achy, or oftentimes it could be more sharp and lancing. It may radiate down the leg, and that raises a point of not being tricked into thinking always that it's the hip that's involved, and making sure to think about radicular pain from L2 and L3, perhaps, that kind of run down the leg in a similar fashion. Often pain is worse with lying on that affected side. I've heard that a lot. Like, I can't lay on that side because it just, kills me for whatever reason. So it's an important part of the history. And it may also be worse with things like standing for prolonged periods of time, crossing of the legs, and single leg activities. As far as exam goes, here's some pictures. These were taken from the MSK playbook. This is actually a really nice summary article too of GTPS. But just a picture of a few of those exam maneuvers. So typically you're going to find patients that are tender right over, right to palpation of that greater trochanter. You might be able to elicit similar pain with Faber or Fader, as seen in the two middle pictures there. Interestingly, end range adduction can be positive. And also, you can elicit the lateral hip pain with active internal or external rotation, or resisted abduction, either with straight leg or with hip flexion. All of those would be suggestive of gluteus tendon dysfunction. As far as like more specific or more sensitive testing, on the left, you'll see your single leg stance. A painful 30-second single leg stance on the affected limb, in this paper, was reported to have 100% sensitivity and 97% specificity for gluteal tendinopathy. So a really important predictor. Similarly, I think we all kind of know about the Trendelenburg, so that's quite helpful in diagnosing gluteal medius tears to the rate of like mid-70s for sensitivity and specificity. And one other interesting test is the resisted external derotation test. So similar to how you would kind of set up for Faber or Fader, your hip and knee at 90 degrees, and then you have them externally rotate just from neutral, and then you resist them as they try to move their hip back into a neutral plane. And if that's eliciting their pain, that's 88% sensitive, 97% specific for gluteal tendinopathy. So a pretty helpful study, or a pretty helpful exam maneuver. Like I mentioned before, always be looking for other things like lumbosacral spine disorders or pain, pelvic dysfunction. All those things can kind of mimic greater trochanteric pain. Risk factors, we kind of touched on this a little bit. So older than 40, a female gender is suggested by this paper, obesity, known hip or knee osteoarthritis, arthrosis, rheumatoid arthritis, low back pain. The core instability or gluteus medius weakness at a baseline, some IT tract tightness or contractures, leg length discrepancy, other issues like a plantar arch deformity, or if you're noticing asymmetric shoe wear, or if they're telling you they're running on like an asymmetric surface, like on the side of a road that's, kind of peaked up, and they're putting more, a different stride on one leg versus the other. Those would all be risk factors. Importantly, almost 92% of patients with like a trochanteric bursitis diagnosis in this paper had some other condition as well, like osteoarthritis or low back pain. So these things all go together. So it adds to the complexity of the diagnosis. This is just a giant table with a vast differential diagnoses that you should be considering. The main top left are the things we'll talk about mostly with greater trochanteric pain syndrome. But anytime somebody's got that lateral hip pain, as I've mentioned, there's lots to think about, from piriformis syndrome to femoral head avascular necrosis and hernias, to lumbosacral spine disorders, to referred pain from things like IBD or IBS or ovarian cysts. So, casting that or keeping your mind kind of open when working through these things is important. So we talk about a little bit of the pathophysiology. Again, with such a broad differential and complex anatomy, the pathophys can be just as broad, and lots of things to think about. Trauma to the hip. So often you could see bruising, you could see abrasions that may occur from direct trauma and could lead to tendinous injuries right over the greater trochanter there. It could cause a traumatic bursitis of some of those bursa. Hyperadduction injuries can certainly lead to strains and tears of this anatomy. overuse, faulty mechanics can lead to, tendinous injuries, IT impingement. There's this thought about friction trauma with an impingement syndrome from the iliotibial tract could play a role on the gluteus medius and minimus tendons as well. There's isolated trochanteric bursopathies, which would be crystal deposition or infections in those bursa. There are more like intrinsic tendinoses, such as angiofibroblastic tendinosis. And then interestingly, calcifications tend to be seen fairly frequently and are playing some role. This is an ultrasound image of a hip. So 13 to 40% of some studies for greater trochanteric pain syndrome found calcifications near the greater trochanter, typically right near the insertion site at the greater trochanter of those two tendons of the gluteal medius and minimus. Most often, though, not in the bursa itself. So again, taking some of that focus away from the bursa and more on the actual tendons around this area. This image is showing some of those hyperechogenic focuses or foci right there. Number 4 there is what that's looking at. Likely an intratendinous calcification. So instead of, I think historically thinking about the bursa as the main cause of this lateral hip pain, this paper wanted us to talk more about or identified the hip abductor tendinopathy as the main cause. This was seen in some studies they talked about. There's an MRI study that showed 14% of patients with lateral hip pain had a tendinosis or tear in one of those muscles. And only 5% had any kind of bursal fluid accumulation. And another study was even more convincing, with 46% having gluteus medius tears, or at least 63% with some sort of tendinopathy, and 0 with any kind of trochanteric bursitis. So like not seeing anything. And I'll have more to say on that in a little bit. So what's actually going on? If it's truly the tendons that are affected and causing this pain, we'll talk about the pathophys behind that. So Bunker et al. Found on their studies that most injuries and tears to those tendons are anterior on the muscle or myotendinous area, right near the insertion on the greater trochanter, suggesting some sort of intrinsic tendon issue. They described as deep, oval, rolled edges, the bones showing, some chronic changes, sclerosis and osteophytes. And interestingly, they pointed out that if there was thought to be like an external impingement from like an IT tract or friction or something like that, that the pathology would be more superficial, but in this case, it's not. It's actually intratendinous. Silva's group in 2008 was looking at the pathology of bursa specimens from patients who had a diagnosis of trochanteric bursitis, and found none of the bursa specimens had acute or chronic inflammation, which I thought was pretty striking. And there was another study with 24 participants with greater trochanteric pain syndrome who underwent surgery and commonly was found to have tendon degeneration, but no acute bursitis. So kind of hammering home the idea that maybe this isn't the bursitis in these chronic pictures at all, and this is actually purely tendon issue. And this picture here just shows kind of where they were seeing those defects in the tendon right there at the myotendinous kind of intersection and right at the attachment site. So diagnostic imaging, they made it clear that, it can be helpful if you're having some questions around the diagnosis, but often this is a clinical diagnosis and it may not be necessary to reach for an MRI or an X-ray. However, they can be helpful if it's unclear. You may see some calcific tendinopathy, bursopathy, or osteophytes near the greater trochanter. An MRI may show degenerative changes to the tendons, atrophy, fatty degeneration. And an ultrasound, according to the Farring et al. Group here, in skilled hands at least, has a very high predictive positive value. For peritrochanteric abnormalities, you can see the tenohypertrophy, heteroechogenicity, neovascularity, disrupted tendon architecture, and also the ability to see partial and full thickness tears, which can be really helpful with your management. This image is a T2 weighted MRI of the bilateral hips, and it's showing an increased signal right where the gluteus medius, which is number 1, and the gluteus minimus, number 2, are inserting on the greater trochanter, consistent with a tendinosis of those muscles. It's something you may see in your practice. So treatment. Initial treatment, as with most of these things, rest, activity modification, avoiding exacerbating movements, avoiding lying in the lateral decubitus position on the affected side, propping up the hip with pillows. This paper did suggest ice and acetaminophen, but was hesitant to recommend NSAIDs now that we are considering more of a tendon damage of the tendon picture and less of a bursitis, and that you could potentially harm any healing that may happen, but it is good for pain control. In 2012, when they were reviewing some of these physical modalities, a lot of things like cryo and therapeutic ultrasound and STIM hadn't been shown to affect long-term outcomes, but did seem to help with pain control if also done with a rehab program. Rehabilitation looks like passive and active stretching, so kind of generally what you would expect for tendon repair and tendon rehab. Focus on the IT and TFL if there's issues there. Considering eccentric exercises, as we've seen with like Achilles injuries and hamstring injuries. Eccentric exercises seem to be really helpful in recovering from those. A focus on core strength, flexibility, and any biomechanical contributors like leg length discrepancy or arch or foot core issues are important. Interventions. So I think historically one of the principal treatments that people have reached for is a corticosteroid injection, or landmark ultrasound guided right into the bursitis or greater trochanteric area. This was thought to and showed to prove or provide some short-term pain relief, but not necessarily great for long-term, and was inferior to exercise and to actual shockwave therapy. And you can understand it now. If it's failing to address the underlying pathology of a tendinopathy, you can't expect it to offer long-term support or long-term pain relief. This paper mentioned that shockwave therapy on its own is very helpful with pain and function from 1 month up to 15 months. There's a study by Furia that showed improvement in symptoms. Didn't really talk about regenerative or proliferative medicine or therapy at this time. It was just understudied for them. And then the last thing that would consider would be surgery. If you're identifying painful full thickness or high grade partial thickness tears, you may be reaching out to your local ortho colleague for their impression of things. There's one additional study that they talked about I'll quickly touch on, and this is the effectiveness of an ultrasound guided injection for the treatment of gluteus medius tendinopathy. So this is with patients that they've got some sort of tendinopathy going on in that tendon. There were 54 patients, heavily female, predominant 48 to 6, ages roughly around in the mid-50s. They used a visual analog scale to assess pain. A hip ultrasound was completed to diagnose with the gluteus medius tendinopathy, and then an ultrasound guided injection with triamcinolone and bupivacaine was given, and they followed up over a period of time. So as you can see, 55% there was a 55% average reduction in pain before and after. At 1 month, 72% of patients had significant improvement in pain, and 70% were satisfied. You can see on the left just kind of what those ultrasound findings look like for this disorder. Hypoechogenicity again, loss of fibrillary pattern, intensified calcifications and tears, which you can see in these images that are labeled. So something that is helpful, I guess, is once we have identified the pathology, and we're actually targeting it with ultrasound guided steroid, this seems to have a much better outcome, and patients are quite happy with this treatment. So overall, we've talked about how this is a common disorder and can be challenging to manage with the complex anatomy and various etiologies that you need to consider. We've talked about how the thought about this lateral hip pain has changed from a bursitis to more of a tendinopathy picture, and we're now focusing more on the hip rotator cuff, if you will, or those abductors, and pelvic core instability as the main cause, and less of a bursitis itself being the sole reason for pain. So yeah, thank you so much. These are my resources. Appreciate it.
Awesome. Thank you, Dr. Witt, for your presentation. I also liked how some of the things were organized in tables, so thank you.
Yeah.
Before going into any questions, I just wanted to give the opportunity to Dr. Troxler to share any additional thoughts or comments about the article's topic.
Great job, Dr. Witt. And I think the key is he brought some additional articles to the lecture, and that's always very impressive, especially when you become a fellow. They're going to really rely on those additional resources. It shows you really mastered the topic. And And I've probably done hundreds of injections thinking in the years ago it was a bursitis, and I probably got the same result. Half got better, half didn't, before ultrasound. And really the key to these articles is more of a tendinopathy and not a bursitis is the key take home. And maybe therapy is probably the best way to go. And like the groin, the hip is very complex. A lot of people say they have hip pain, but they really have back pain. And so you really have to ask them, where they hurt. And most people, when they think of their hip, they think of their back and not their hip. So important in the history. And a lot of people alternatively have IT band syndrome. So again, injection usually doesn't help that. And so really clarifying the location is probably the key. And we're non-surgeons, we're diagnosticians, and that's kind of right up our alley to get, become experts on the exam. Doing ultrasound or MRI kind of just confirms what we already know typically. And but great job and awesome presentation. Thanks a lot.
Thank you.
If anyone has any questions that they would like me to read, feel free to put them in the chat and I can ask them. Or if you want to ask them yourself, you can unmute and ask the question too. And I did have a question, Dr. Witt. I feel like I really like using the greater trochanteric pain syndrome and kind of explaining it like, oh, it's this huge umbrella term. Do you remember when you were first introduced to the topic as a learner as well? Do you appreciate that type of like organization?
Yeah, I found it to be at first I think maybe a little bit I don't know if it was intimidating or it was just like, oh boy, I thought I had a simple answer for pain in that area. And I thought I had a pretty simple treatment option. And then, yeah, I do remember it was, not that long ago that somebody's like, well, it could be bursitis, but, you really need to consider what's going on in the hip muscles. And I was like, oh, okay. And then I stumbled across this paper after talking to another mentor of mine. And yeah, I mean, it definitely, I think is a much more accurate way, I think, of thinking about this and making sure we've got the right diagnosis and providing a better treatment route for patients. So, but yeah, it was definitely an eye opener and made me rethink some things about my management.
Good. I feel like we often, a lot of us always use, I try to explain that to patients too, because how many times did the patient be like, I have bursitis, and they point there, and then I try to redirect as this whole umbrella term, and we got to figure out why. So
Right.
I'm glad it also comes across that way when you were learning it too.
Sure.
If there's no other specific questions, and if there is, if someone thinks of a question, we can always talk about it at the end too. I'm actually going to move along to our second presenter tonight, and that is Dr. Salina Halliday, and her club mentor is also Dr. Mark Troxler. So Dr. Salina Halliday is a PGY4 in physical medicine rehabilitation and is a resident at Mary Free Bed Rehabilitation Hospital in Grand Rapids, Michigan. She'll be completing her residency this summer and pursuing a fellowship that specializes in musculoskeletal health and limb loss through Virginia Commonwealth University in Richmond, Virginia. So congratulations. Dr. Halliday has a 10-year history of working with D1 athletics as an athletic trainer prior to medical school, and she has a career interest in working with adaptive sports. Her presentation tonight is on the article Surgical Management for Chronic Exertional Compartment Syndrome of the Leg, a systematic review of the literature. And then I'd also like to thank Dr. Mark Troxler for serving as her club mentor. And for any of the anyone who's just joining or maybe joining later, just to introduce Dr. Mark Troxler again. He is a private practice at McKinley Internal Medicine and Sports Medicine in McKinley, Texas. And he is the chairman of anti-doping education for USA Track and Field. He's a team physician for high school and at the collegiate level and with USA Track and Field. He completed medical school at Oklahoma State University College of Osteopathic Medicine in Tulsa, Oklahoma. His internal medicine residency at University of Oklahoma College of Medicine, Tulsa campus in Tulsa, Oklahoma. And he completed his sports medicine fellowship at Jersey Shore University Medical Center and Rutgers in Neptune, New Jersey. and received an MBA degree at the University of Massachusetts, Amherst campus in Amherst, Massachusetts. So I'm going to turn it over to you, Dr. Halliday, or you can go ahead and share your screen and start the presentation.
All right, thank you. We'll work on sharing. So thank you for the introduction. And thank you to Dr. Troxler for acting as my kind of club mentor for this, journal club mentor. I am talking about surgical management for chronic exertional compartment syndrome. This is a systematic review. And yes, I'm a 4th-year resident, and yeah. So learning objectives today, I wanted to talk about the etiology and pathophysiology of exertional compartment syndrome. So in the lower leg compartment, just anatomy review, and then the most common compartments that are affected as well as their associated symptoms. Then we'll talk about some current treatment options, conservative versus surgical, and move on to kind of what the study talked about more with the conclusions and limitations of the study. And I apologize if I sound a little ill. I'm coming off of having the flu, so working on trying not to sound terrible here. So exertional compartment syndrome, it's normal muscle physiology to have some form of increase in muscle volume with activity. And usually that muscle volume is about 20%. And it does increase compartment pressure, but it should return to normal within about 5 minutes. So with exertional compartment syndrome, the pathophysiology behind it isn't super well determined yet, but overall they're finding that there's this endurance activity overall causing increased pressure within a fascial compartment. And because of this increased pressure, it gets so high that it can cause kind of a temporary ischemia, hypoxia, and ultimately transient neuropraxia and pain. So the compartments that were most affected in this article by Finoff and Reisner, or chapter rather, were the anterior compartment, 40 to 60%, and then the deep posterior and lateral were pretty comparable depending on the research, but lateral tends to actually be a little bit more. And then the superficial posterior is pretty rare. Epidemiology, it's previously been shown in literature that it's kind of equal for male and female. And then young athletes and military are most commonly affected. So somebody that has endurance activity kind of in their day-to-day life. So runners are the number one, and then soccer players are pretty close behind. And this is for both recreational and competitive athletes. And then the clinical features that you see most commonly would be pain on exertion and typically seen with repetitive use. So again, endurance activities with resolution of pain at rest. And these can be pretty challenging to diagnose. And there's actually an article that said the general timeline for diagnosis can be up to 28 months on average. So pretty delayed diagnosis at times. And the failure to properly diagnose can actually lead to longer-term pain, which we'll get to towards the end. So just a review of our anatomy and the compartments. We have our cross-sectional view of our lower leg here. This is the tibia and the fibula. And then our anterior compartment, all in blue here, we're going to have our anterior tibialis, extensor hallucis longus, extensor digitorum longus, and then further down in the leg, you can't see it here, is going to be the peroneus tertius. And then the deep peroneal nerve is represented in the anterior compartment. The lateral compartment's a little bit simpler. It just has our peroneal longus and brevis, or fibular longus and brevis, as well as the superficial fibular peroneal nerve. The superficial fibular does exit the fascia about 1/3 up from the ankle on the distal aspect of the shin there. And then the superficial posterior, again, this is the most rare one, but it contains the plantaris, the gastroc, the soleus, and then some of the tibial nerve and the sural nerve as well. And the deep posterior is going to contain the flexor digitorum, tibialis posterior, flexor hallucis longus, popliteus, and the tibial nerve there as well. So the tibialis posterior, there have been some anatomy reviews that looked at this specifically because they found that this may be kind of a pseudo fifth compartment because oftentimes it does have its own fascia surrounding it. So for the anterior compartment, this is again affecting tibiant, EHL, extensor digitorum longus. So these are all kind of our dorsiflexors. So if somebody's been running for a long time, they're getting anterior compartment syndrome in the anterior compartment, then they may exhibit some weakness in the dorsiflexors. So they might have a drop foot or slat foot gait. They might have a steppage gait to kind of compensate and clear that foot. They may have numbness and tingling in the deep perineal distribution, which is that first dorsal web space here. For the lateral compartment, it's going to be, again, our everters, the peroneus longus and brevis. And it's also going to affect that superficial perineal nerve. So with eversion, if this is weaker, you may consider increased risk for lateral ankle sprains, those kind of things. I don't know that that's been very well studied yet, but if you're not able to evert, you could be at more risk there. And then sensory-wise, you'll have decreased sensation or numbness tingling along the superficial perineal region, which is the anterolateral portion of the distal aspect of the leg, and then into the top of the foot. Superficial posterior and deep posterior both tended to have a bit of kind of this overlap of symptoms, but mostly cramping, posterior calf pain. Over time, as it became a little bit weaker, they'd have difficulty with raising on their toes. And then a distribution of numbness and tingling into the plantar aspect of the foot. And many of the articles said that it was felt more on the medial side of the plantar aspect of the foot than the lateral. The tibial nerve does split into the medial and lateral plantar nerve, so kind of unclear as to why it may affect the medial side a little bit more. As far as diagnosis, the gold standard test is the pre-exercise and post-exercise intracompartmental pressure testing. And what we've seen quite a bit, or what used to be kind of the gold standard, was the Pedowitz criteria. And this is looking at pressures before starting exercise and then pressures again after exercise at 1 minute and 5 minutes. And then they kind of use these pressure measurements to gauge off of. So if it's over any of these measurements in those timelines, then they would meet criteria. And then you can see here, they have the pressure monitor looking at each of these different compartments. This gentleman is not wearing gloves. I do recommend wearing gloves because if you've seen this procedure, it is actually pretty bloody. So protect yourself and your patients. For treatment, I looked at this systematic review put out in 2021. They did a really nice job of actually talking about the conservative treatments. And what's out there is basically cessation of provoking activity, physical therapy, shoe modification, and gait retraining. With the gait retraining, what they're focusing on the most is forefoot running. And the concept behind that is basically to decrease the amount of eccentric load on the anterior compartment. So if you're heel striking, you're putting a lot of eccentric load on that anterior compartment, which creates a lot of stress and wear and tear on the structures within that compartment. So forefoot striking is thought to actually help reduce that impact. And it has shown some benefit, especially in the military population, even when kind of the issue of wearing boots is taken out of the conversation. And then also for those that failed surgical treatment. Botox has also been studied a little bit, but this has been looked at with very low numbers, so kind of inconclusive results. But Botox, again, is a neurotoxin, inhibits the acetylcholine release from the nerve terminal in the neuromuscular junction. So with Botox, you're also going to induce a little bit of weakness into that muscle, which may not be the best option for endurance athletes. So if somebody's failing conservative treatment, they move on to surgical management. And there's a lot of different techniques. Most commonly we're not doing, but surgeons are doing the fasciotomy, especially for athletes. Fasciectomies are out there as an option too, but there's some concern that maybe you reduce the strength of the structure if you do a full fasciectomy. And then there have been found some complication rates, 4 to 19% complication rate, and about 45% recurrence rate in some articles. You always want to think about your differential diagnosis, medial tibial stress syndrome, stress fracture, fascial defects or herniations, and then popliteal artery entrapment syndrome, claudication, as well as your lumbosacral radiculopathies. So it's a much more expansive list than this, but at least think of these ones. So why is this important? This has been shown to be a very common source of pain for athletes, especially in the military or higher level athletes. And it's estimated to be anywhere from 13 to 35% of cases of lower extremity exertional leg pain. Conservative treatment failures are pretty common per this article, and surgical treatments kind of have mixed results and high recurrence rates. So they wanted to just do a more systematic review and check in on all of these things. So they really focused in on operative indication, surgical techniques, functional outcomes, reoperation rates, and complication rates. And the hypothesis was that operative management of chronic exertional compartment syndrome of the lower leg would offer moderate symptomatic relief, but with a significant rate of complications and reoperations among the young and athletic demographic. So they did a web-based search for articles from 1970 to 2015. Search terms kind of included just anything that included exertional compartment syndrome. They looked for peer-reviewed clinical studies, level 1 through 4 evidence, and case series with greater than 5 patients. And then they wanted a good follow-up, so at least 6 months out and 80% follow-up. For demographics, they looked at age, sex, occupation, and then activity profile. If they're athletes, military, what level of athletics they pursued. And then for outcomes, we kind of touched on this already. I just wanted to emphasize what they defined as clinical success. They said it was one or more of the following. So good or excellent patient-reported outcome on the Likert scales, or postoperative patient satisfaction, i.e. would have surgery again. And then they also included complete resolution of pain or exertional symptoms and return to preoperative level activity. And the reason they kind of defined clinical success in this manner is that each of the studies they looked at all had different ways of measuring clinical success. So they were trying to create a little bit more of an umbrella. For their stats, they did calculated weighted averages, which are useful for giving different levels of importance for different data points. And it can create a more accurate representation and more relevant, reliable data points, but they didn't really discuss how they did the weighted averages, so there's a little bit of subjectivity in that as well. Yeah. For the study selection, they started with 204. We whittled it down to 13 just from review. And then from those 13, they looked into the citations and found 11 more. So ultimately had 24 studies. They had about 1,500 surgical treatments with an average number or power of each study of about 67, and the average age was 26.6 years old. They did have more males than females represented by, it was about 70%. They were mostly military. I think it was 7 out of the 24 studies were military, so that makes sense. And then 29% were athletes, and 50 of those 29% were actually endurance runners. For operative indications, I liked this quote from their study. It said there's a lack of unity in accepted diagnostic criteria. So their surgical indications were kind of all over. The most common one was that pain on the athlete had pain on exertion that subsided with rest. The second most common was paresthesias, and then only 9 of the studies used failure of non-surgical treatment. So, you know, maybe these athletes or military personnel didn't even really undergo a conservative treatment regimen. Maybe they just kind of jumped right to surgery. So a little bit hard to say. A study that I looked at from 1983, looking at just surgical treatments, they all had kind of a very specific must fail conservative therapy first and then prove elevated compartment pressures before moving on to surgery. And the elevated compartment pressures wasn't really part of this table at all, but they did have 21 out of 24 did look at the compartment pressure testing prior. So 9 out of 21 of those actually did the Pedowitz criteria, and then they didn't really define what the other criteria was. They talked about other possible criteria as being maybe even more sensitive and specific than the Pedowitz, which is coming out. This was called the Rusco criteria, I believe, but they didn't say whether these other studies actually did the Rusco criteria or what criteria they used. They just talked about compartment pressure testing. A couple other studies did do bone evaluations with bone scan and x-rays, as well as vascular studies to rule out other possible diagnoses as well. So the surgical techniques that they did for the anterior compartment, 10 of the studies did a single incision technique, 6 did a two incision technique, and for the deep posterior compartment, they all did a single longitudinal incision. For the lateral compartment, it wasn't very well specified or defined. And for the rehab protocol, it was highly variable. So it was as conservative as bed rest for 4 days after surgery to as aggressive as immediately weight bearing right after surgery. And most of them honestly didn't even specify. They just kind of didn't talk about the rehab protocol at all. For outcomes as per compartment, each athlete or each individual, about 80% of them had bilateral procedures done. And the anterior compartment was by far the most common, which is consistent with previous studies. And the anterior compartment also had the best outcomes. The lateral compartment was found to be the second most common, and then the deep posterior, the third most common. And the deep posterior was actually had the most inferior outcomes. And this is kind of consistent with previous research as well. There was one study that they talked about in this article where a surgeon had 100% success rate with his deep posterior compartment surgeries. And per their discussion, they said that he was kind of questioning other surgeons' abilities. So kind of an interesting thing to say in an article. And then the superficial posterior, again, is pretty uncommon, only 3%. And there was multiple compartment involvement for some of these individuals, and they tended to have worse outcomes than those that just had single compartment involvement. So the deep posterior compartment tends to be a bit of a problem child consistently. This study looking at 12 subjects that had surgery from 1983, they looked at 4 different compartments, types of surgeries, but only 3 of those 12 had deep posterior compartment surgery, and 2 of the 12 had surgical treatment failures. So 2 out of the 3 posterior compartments had surgical compartment failures, and everyone else did quite well. So they theorized 2 possible explanations. They said maybe they were incorrectly diagnosed, but their workup for these individuals was actually very extensive, so they thought this was quite unlikely. And then they also said maybe it was just an incomplete fasciotomy, which they thought was more likely, and they kind of went into it a little bit. This is the 2 incision technique done for the anterior compartment. And you can see it's relatively simple. I mean, I'm not a surgeon, but you do your 2 incisions, and then you find the fascia right underneath and kind of cut away that fascia. Whereas with the deep posterior compartment, you do your 2 incisions, and then you have to detach the soleus from the back of the tibia and retract it, and then below that you'll find your deep compartment. So a little bit harder to visualize, a little bit harder to do. And they recommended maybe doing 1 long surgical incision instead of these 2 small incisions. But interestingly, that's kind of what all of these articles did. They did this 1 single long longitudinal incision. So something to think about. We're still having trouble with that posterior compartment. We have since 1983. Kind of unclear as to why. Maybe it has something to do with that questionable fifth compartment of the tibialis posterior, but pretty unclear. And then success rate overall was about 66%, as defined by what we talked about earlier with the Likert scale, etc. And there was some possible associations with a subgroup analysis too. So age, they showed that younger was better. High school and college athletes did much better than their post-collegiate peers. As far as level of participation, this hasn't been super well defined or studied yet, but they saw maybe a trend towards better outcomes for collegiate and higher level athletes compared to others. For the compartment, again, the posterior compartment has some pretty well backed evidence that it's the most inferior outcome. And then as far as chronicity, they said there's I believe 4 articles that really emphasized there's a worse outcome for those that have symptoms greater than 12 months. And if we remember how long it can take to get diagnosed, sometimes greater than 28 months at times, this can be a problem. And then again, those with multiple compartment involvement tended to have worse results. So this is our clinical and functional outcomes. We showed the 66 overall cumulative success rate through the Likert scales. And then for patient satisfaction, 84% of patients opted they would have surgery again. And for full return to play or activity, it was about 75% of the patients between 6 weeks and 4.7 months. Regarding recurrence of symptoms, 0 to 20% kind of required reoperation, and 72% of those reoperations were successful. And for complication rates, there was about 13%. The most common complication rate was nerve-related injury, and this was most commonly just more subjective numbness, tingling, rather than like a drop foot, etc. So they found this was mostly the superficial perineal nerve. Sometimes there was fibrotic scarring around where that exits from that distal fascia. So that was another reason for reoperation rates as well. So main takeaways were that primary surgical management of chronic exertional compartment syndrome in the lower leg has a cumulative success rate of 66%, and 84% of those were satisfied with the surgical outcome at short and midterm follow-up. And most of these are looking at a follow-up of 48 months. The risk of complication was about 13% in young athletic population, and risk of reoperation was 6% in the young athletic population. They said that open fasciotomy remains the predominant technique. I think it represented 86% of the surgical techniques in this study overall analysis. And then deep posterior compartment tends to have the least favorable outcomes. So study limitations, we can talk briefly about these, but it's a systematic review, so it's dependent on the quality of constituent studies. There's a lot of variability in each of the studies, so compiling them into one big definable answer is challenging. And there is a little bit of risk of bias in some of the studies, with retrospective studies having recall bias, etc. These are my references. And I guess I will turn it back over to Dr. Heasley and Dr. Troxler.
Awesome. Thank you, Dr. Halliday. And then again, before any questions, I just would like to give their club mentor, Dr. Troxler, any opportunity to have any comments or anything else about the topic.
Sure. Excellent presentation. Very detailed. Really appreciate that. And both Dr. Witt and Dr. Halliday will be taking the sports medicine exam next year. And so there's at least 10 or more questions on compartment syndrome. There's not as many on hip. And they'll try and confuse you. And they don't ask a direct question of like, which compartment is this muscle in or this nerve in, but you have to know it to answer the question. So they'll say numbness between the first and second toe. They won't ask you what nerve it is. They'll ask you what compartment. And then they'll try and give you a case with somebody with back pain and leg pain and try and make you determine, is it an L5 neuropathy or is it a compartment syndrome? So it gets pretty tricky. And AMSSM actually has some practice tests, and they have a test pool of questions of over 100 questions, single best answer. And so if you have 100 questions, and there's 4 answers, that's essentially 400 items you really have to know. And I use that every time I take the test. I took it in 2000, 2010, 2020. And that exam they have is very, very, very helpful. And you really, the key is with a term called overlearning. And so you really can't, especially with the compartment, you can't say, kind of figure out, kind of know how it is. I'm going to figure it out on the test. That doesn't work. You really need to know by detail. That one slide Dr. Halliday had, where it showed the compartments, what's in it, etc. Really need to know it. And one thing the article doesn't talk about is with compartment syndrome, some athletes, the pain will continue after they run, like 30 minutes after they stop playing soccer, they still have the pain, versus the pain stopping immediately when they stop running. So if pain stops immediately, that's more of a vascular component of the compartment. If the pain continues 30 minutes after the activity stops, that's more of a neurological. So one is affecting a nerve, one is affecting the blood vessel. So very key difference. Overall, great job. And I'll leave the questions to everybody else.
Awesome. One question we have says, I'm curious if either Dr. Troxler or Dr. Halliday have thoughts about why there aren't more recent or current studies about compartment syndrome given the high incidence.
I think there are, and feel free to butt in, Dr. Troxler, but like the systematic review from 2021 looked at, I think it started its database from like 2012 or 2015. So there are a lot of other research articles out there, but that wasn't on our list of articles to review. So I think the research is still being done and advanced.
And then one other question here. Zach says, I've seen one case of compartment syndrome in an endomorph type special force soldier. I apologize if I missed it, but did you find what subpopulation among military or runners is more susceptible? Is it those with more muscle mass commonly, or just maybe unfortunately dealt genetic hand?
It did not define specific like body types or anything within this study that I looked at, or any of the studies that I looked at, really. All it leaned more towards was that they were endurance athletes usually. And military, I think I could do a deeper dive to see if it's for military, if it's like immediate recruits that are going through boot camp and going, a lot of them from 0 to a whole lot of activity, or if it's those that have been in the military a long time. I'm sure there's research on that. I just didn't personally see it.
When it comes to track and field, we have a national championship every year, junior and the junior championship and an elite championship. And usually with our youth athletes at the national championship, we have 12,000 athletes. And I haven't seen a case in a youth athlete ever. And in our college athletes, it's not uncommon. And then of course, our elite athletes, it's probably the most common. And it seems like the more trained they are, probably increases the incidence.
All right. Thanks, everyone. We are going to go to our third presenter tonight. I'm going to introduce Dr. Erika Mehta and her club mentor, Dr. Craig Pille. Dr. Erika Mehta is an emergency medicine PGY1 resident at Capitol Health Emergency Medicine Resident Program in Pennington, New Jersey. Why sports medicine? She has always been an athlete and played a variety of sports from competitive swimming to powerlifting, and she's definitely had her fair share of sports-related injuries. Her love for sports medicine often stems from a passion for both sports and helping people recover from injuries to regain their physical abilities. She is drawn to the opportunity to work closely with athletes and active individuals and manage their health and performance holistically. Her own personal experience with sports injury provided firsthand insight to the importance of injury prevention and rehabilitation, which is what she'd like to carry forward with her patients. Her presentation is on the article Pediatric Elbow Injuries. I'd also like to thank Dr. Craig Pille for serving as her club mentor. Dr. Pille is a primary care sports medicine physician at NYU in New York, New York. He completed his fellowship at the University of Maryland in Baltimore, Maryland, and before that was a family medicine resident at the University of Massachusetts in Worcester, Massachusetts. His passion for sports medicine lie in care of the overhead throwing athlete mental health, and team coverage. His love for sports started at a young age. He and his neighborhood friends built a regulation-sized Little League baseball field in the neighbor's backyard, so they were never far away from the game. And I'm going to turn it over to you.
Okay, so to start off, elbow trauma in children is probably one of the most encountered musculoskeletal injuries in pediatrics. Secondary ossification centers are unique to pediatric patients, and it's the reason why these injuries can often be misdiagnosed. Familiarity of elbow anatomy unique to children is therefore necessary for an accurate diagnosis. So many elbow injuries can be diagnosed with x-rays. However, there are specific scenarios where other imaging modalities, such as CT, ultrasound, or MRI, would be essential for an appropriate diagnosis. So the article that I reviewed seeks to improve diagnostic accuracy of these elbow injuries by reviewing these secondary ossification centers and discuss common acute and chronic elbow injuries in the pediatric population specifically, as well as highlight situations in which other forms of imaging played an important role in diagnosis. So some of the imaging modalities, so X-ray, we all jump to X-rays as our common first choice. However, we can use an ultrasound, which is an excellent imaging modality to assess secondary ossification centers in the elbow. Since these ossification centers are partially ossified or unossified in a young child, the ultrasound would allow us to evaluate the congruency of the elbow joint. MRI is also an excellent modality to assess bone marrow, cartilaginous structures, or soft tissue abnormalities. It's also the preferred imaging modality when evaluating cartilaginous structures like articular surfaces and secondary ossification centers, physeal injuries, osteochondral lesions, and soft tissues such as ligaments, tendons, and muscles. CT is also an excellent tool to assess for any loose bodies in the joint, and it better delineates the cortex of the bone in the setting of a subtle cortical break, or seeing a small nidus in a case of osteoid osteoma. So what even are these ossification centers? So there are 6 ossification centers in the elbow, which appear and ossify depending on the child's age and sex. So there are 6 of them, and this is the mnemonic. It's cry-toe. So you can see the capitulum, which is labeled as C, the radial head, which is R, internal medial epicondyle, the trochlea, olecranon, and the external lateral epicondyle. And so that's the mnemonic cry-toe. So as you can see in this lateral view, it's important to notice that a displaced medial epicondyle in the humeral trochlea groove, so like the eye over there, that would be a displaced medial epicondyle, whereas like in the frontal view, you can mistake that as just a regular trochlear ossification center. So it's important to know where these ossification centers are and like which view you're looking at them in, because it looks normal in the frontal, but in the lateral, you can see, you might think it's normal, but it's actually displaced. So classification of elbow injuries, you can classify them into acute and chronic. So we'll first talk about the acute injuries such as elbow joint effusions fractures, supracondylar fracture of the distal humerus, lateral condylar fracture, medial epicondylar fracture, proximal radius fracture, and olecranon fracture. And then we'll talk about the two chronic. So to start off with the acute injuries, we have an elbow joint effusion and fracture. So on the lateral x-ray of the elbow, you can see a joint effusion can be inferred when there is displacement of the anterior fat pad or presence of a posterior fat pad abutting the distal humerus. So you can see that with the black arrow, you can see the anterior fat pads, also called the sail time sign. And then there's a posterior fat pad, which is the white arrow. So a joint effusion without a visible fracture seen on a plain x-ray is often associated with an occult fracture and bone marrow edema on an MRI. So you can see in the MRI in the sagittal view that demonstrates marrow effusion and edema labeled as the asterisks. And so these findings would be consistent with a occult fracture. So in cases where there is an occult fracture, follow-up radiographs in 7 to 10 days can be obtained to evaluate the presence or absence of sclerosis or periosseal newborn formation. So the next one, supracondylar fracture of the distal humerus. It's the most common elbow fracture seen in children, accounting for 50 to 70% of cases. The peak age would be 6 to 7 years old. The mechanism, around 6 to 7 years, the supracondylar process undergoes bony remodeling, and this causes cortical thinning of the region, which then predisposes to fractures. So then when a child falls on an outstretched hand, they have a hyperextension stress on the elbow, and this causes posterior angulation or displacement of the distal humeral fragment relative to the humeral shaft, which then disrupts the anterior line. So you can see this patient is falling on their outstretched hand and causing angulation. So in the lateral view, you can see there's a completely displaced supracondylar fracture, and you can see the black line, which abnormally passes anterior to the middle third of the capitulum, and even entirely anterior to the capitulum with a disrupted cortical margin, which you can see it's anteriorly displaced. And so that would be a Gartland type 3. Then you have a Gartland type 1, which here you can see the fracture and the displaced anterior fat pad in the presence of a posterior fat pad, which then would indicate there's a joint effusion. And then with the black line, you can see that it bisects the capitulum, which is an expected normal finding. So here there's no displacement, whereas in Gartland type 3, there is a displacement. In Gartland type 1, there's no displacement. So you can see that in the frontal view too. There's some lucency with black arrows, and that would be in the supracondylar distal humerus, and that would be indicative of a type 1 Gartland fracture as well. So 5% of the supracondylar fractures are of flexion type, so that would be from a direct force to the flexed elbow, and this would cause volar displacement of the distal humeral segment, and then the anterior humeral line will abnormally pass posteriorly to the middle third of the capitulum. So you can see that it's posteriorly displaced in this picture. Next, we have the lateral condylar fracture. So this is the second most common elbow fracture, which is seen in children, accounting for 10 to 15% of cases. The peak age is 6 to 10 years old. The mechanism, child would fall on their outstretched hand. Their forearm would be in supination, which then causes a varus force on the elbow. So this non-displaced lateral condylar fracture is often very subtle and therefore challenging to detect on regular x-rays. So you would see the secondary signs of injury, including joint effusion and soft tissue swelling, which may provide clues for the presence of a lateral condylar fracture. So here you can see on the left, you have the Milch type 1, and that would start at the lateral metaphysis of the distal humerus, and it extends to the capitular ossification center. And so you can see that with the two arrows. So this type of fracture would be considered stable, whereas the Milch type 2, it starts in the lateral metaphysis of the distal humerus, and then it extends towards the capitular trochlear groove, which you can see and compare and contrast the two. This type of fracture is unstable and then would require emergent surgical consult. So one of the shortcomings of the Milch classification system is that most fractures involve the cartilaginous portion of the bone, and therefore it's mostly seen as normal on regular X-ray and better seen on an MRI. So here you can see on an MRI, there's a minimally displaced lateral condylar fracture. You can see with the arrows extending into the trochlea, and you can better see it here than in the X-ray, and this would be unstable and an emergency. Next, we have the medial epicondylar fracture, and this is the third most common elbow fracture seen in children, accounting for 10% of cases. The peak age is early adolescence, and essentially the mechanism is a fall in an outstretched hand. And then here we have a valgus force on the elbow instead of a varus. And this would cause an avulsion fracture of the epicondyle, which is pulled by the common flexor and the pronator tendons. So here in the frontal view, you can see that there's an avulsion fracture of the medial epicondyle, which is marked by the asterisk, and that is displaced distally. The medial epicondyle is located to the dorsal side of the elbow, and with further avulsion, the medial epicondyle will move further anterior to the volar side of the elbow, as you can see with the asterisk in the middle as well in the lateral view. Then the oblique view, this demonstrates an avulsed medial epicondyle fracture in the ulnar trochlear groove. So 30 to 50% of medial epicondylar fractures are associated with elbow dislocations. And when the elbow is dislocated, the medial epicondyle is avulsed, and it can sometimes be entrapped within the ulnohumeral joint. And so this complication must be recognized to avoid delayed diagnosis and prevent damage to the elbow injury or to the elbow joint. So for that, CT can be utilized to confirm displaced medial epicondylar fracture within the ulnohumeral joint, especially in the setting where it's confusing because this medial epicondyle normally can be unfused or incompletely ossified, which would be normal, and it can also have fragmented ossification centers. So sometimes it looks like it's fractured, but it's not on an X-ray, and then when you get a CT, you can kind of figure out a little bit better. So here on these CTs, you can see a similar finding of an entrapped medial epicondyle, which is with the asterisk and the arrow. And in a normally the unfused normal fragmented appearance of the trochlear ossification center above the medial epicondyle. So you can see right above the asterisk that that is normal and not a fracture, whereas underneath it, the medial epicondyle is entrapped. Next, we'll talk about the proximal radius fracture. This is one of the rare types of elbow fractures seen in children. The peak age is 9 to 10 years old, and the mechanism, again, is fall in the outstretched hand. There's a valgus force on the elbow, which then the proximal ulna impacts the capitulum and fractures the radial neck. So we have 3 X-rays here. The first one, you can see that a non-displaced radial neck fracture. It's often difficult to see on an X-ray by itself because it looks like there's no fracture in this first picture. In the second picture, in the lateral view, there's a portion of the radial neck that lies outside the elbow joint, and a lack of a joint effusion is not a reliable negative predictor of a fracture in this scenario. So ideally in the oblique view, you can see there's sclerosis where the arrow is of the radial neck, and that would be suggestive of interval healing of a non-displaced radial neck fracture. Next, we have the olecranon fracture. This is another rare type of fracture seen in children. The peak age is again 9 to 10 years old, but it can happen at any age. Mechanism again, fall on the outstretched hand or a direct blow. And this is usually in conjunction with radial head dislocations, radial neck fractures, or medial or lateral condylar fractures. So here we have 3 more x-rays, or the first one's a CT. That one shows an elbow where there's multi-partite appearance of the olecranon. That can be an imaging pitfall because this is a normal olecranon ossification center. So although it looks fractured, it's actually normal. In the middle, we have a mildly displaced fracture, which you can see with the arrows of the olecranon extending to the ulnar humeral joint. And then in the lateral view, that also demonstrates an olecranon fracture. Next, we'll talk about the chronic. That consists of osteochondritis dissecans and medial epicondylar apophysitis. So osteochondritis dissecans is one of the chronic injuries, and the peak age is 12 to 15 years old. The mechanism would be repetitive trauma and impaired vascular supply, and it's usually in athletes. So for this, MRI is often helpful to evaluate early causes of osteochondritis dissecans before X-ray findings. MRI findings can include subchondral edema and regional variable geographic trabecular signaling abnormalities. So here in this MRI, you can see that there's a focal region of abnormal signal in the mid-anterior capitulum where the arrow is, but without high fluid signal undercutting the lesion. So in both, you can see that where the arrow is pointing, there's some kind of signal, and this would be considered stable. So often with these chronic injuries, there can be loose bodies that would be associated with unstable lesions, and that can be identified on an MRI or a CT. So you have the capitular osteochondritis dissecans where the black arrow is, and then you have at least 2 intra-articular loose bodies posterior to the capitulum, which would be the right white or the left white arrow. This would be considered unstable and a medical urgency/emergency and would need surgical evaluation. Last, we have the medial epicondylar apophysitis, and this is again a repetitive trauma and valgus stress over time, usually seen in athletes. And although many of these patients may present with X-ray showing widening, displacement, or fragmentation of the medial epicondyle, majority initially present with normal X-ray findings. So here you can see MRI is a little bit better for identifying this. You can see that there's increased marrow and edema in the medial epicondyle where the arrows are. So in conclusion, elbow injuries in pediatric patients are very common, and understanding the radiographic appearance of these injuries are critical for accurate diagnosis. Although many of these injuries can be identified with conventional X-rays, some injuries are best evaluated with CT, ultrasound, or MRI. Knowledge of which types of more advanced imaging techniques should be used to help optimize patient management. And something just for myself, it is important to know as an EM resident, and definitely found this information useful to enhance our management of pediatric elbow injuries in the ED. Thank you very much.
Awesome job. Thank you so much. And then before any questions, I also would like to give our club mentor, Dr. Pille, an opportunity to share any additional comments about the article or topic.
Sure. Yeah. Great job, Dr. Mehta. I think that this topic can be very overwhelming. It's something that we don't come across in our day-to-day necessarily, especially those of us treating mostly adult patients. And so, just kind of some clinical pearls that I've picked up along the way that may be helpful to provide some context. The Crito criteria, at least from a board exam perspective, is very highly testable, very, very high yield, probably 5 to 6 questions on my most recent boards, just knowing which each of those growth centers is, and then knowing kind of the approximate age that they do onset. And so the easiest way to remember that is CRI-TOE 1, 3, 5, 7, 9, 11, just kind of every odd number as you march through that for age of onset. I think it's super important to know the mechanism of action and mechanism of injury for really the patient that you're seeing in front of you. I think that can help hone in where you're looking on the x-ray, which of these ossification centers are particularly impacted, which bone itself can be impacted. And really don't discredit the presence of that sale sign. Any concern for elbow effusion in a pediatric patient is a fracture until it's not a fracture. And so, using kind of our primary care hats and allowing ourselves the opportunity to, if the fracture is not present the first time around that you see the patient, giving it a little bit of time, treating it conservatively with, an immobilization period, and seeing that patient back in 7 to 14 days and re-imaging can be very, very helpful. A lot of these young kids are throwing callus down very significantly in a very short period of time. And so, it's not unsurprising to have them back at that 2-week follow-up, and boom, there's the healing fracture already visible. And so sometimes you don't see the fracture, sometimes you see the evidence of the bone healing. But overall, I think Dr. Mehta did a great job kind of summarizing all those finer details, but those are just some broad strokes from my perspective.
I was also gonna comment on the 1, 3, 5, 7, 9. I feel like these questions are always on the board exam as well. So great job kind of going through all the extra details.
One additional thing to remember, I see a lot of kids in the ER, and with those ossification centers, if you do one x-ray of the injured arm, elbow, you don't know if it's just a ossification center or an actual fracture. And so I x-ray, and sometimes depending on the nurse and x-ray tech, they always think I'm crazy, but I always x-ray both elbows. And that's gotten me out of missing a lot of fractures. So when you see a kid, whatever the body part, x-ray both parts, because you have a normal and an abnormal, and it's very helpful.
Thank you for sharing that. It's something that I will keep in mind, because everything always looks fractured to me in peds population. So
it's a great tip. Definitely helped me too. All right, I think that is it for tonight. I'd like to thank all 3 of the presenters, Dr. Witt, Dr. Halliday, and Dr. Mehta, for wonderful presentations with great organization in them. I also like to thank all the club mentors with Dr. Troxler, as well as Dr. Pille for serving as the mentor again. And thank you for everyone attending tonight's Journal Club meeting. And then it was also my pleasure serving as the club advisor, moderating tonight's Journal Club as well. And then the last thing is just to continue to look out for announcements of the dates for the next AMSSM Journal Club in March. So that should be coming out soon via email, and then also on our social media and in the member e-blast. And this concludes tonight's meeting. Thanks, everyone. Have a good night.